So in this session, we'll deal with the extraocular muscles. So there are total 10 extraocular muscles. Out of that, 7 are voluntary and 3 are involuntary. The 7 voluntary extraocular muscles are here. You can see the levator palpebrae superioris. You can see the superior oblique. You can see the superior rectus, medial rectus, lateral rectus, and this will be the inferior rectus, and this will be the inferior oblique. So there are 4 recti: superior rectus, inferior rectus, medial rectus, and lateral rectus. There are 2 obliques, the superior oblique and inferior oblique, and there is one levator palpebrae superioris. So if you see the origin of these muscles, you can see the superior rectus, inferior rectus, medial rectus, and lateral rectus. They are taking origin from common tendinous ring of Zinn, which extends across the superior orbital fissure. And you can see here the levator palpebrae superioris takes origin from undersurface of the lesser wing of sphenoid above the superior rectus, and the superior oblique takes origin from the undersurface of the lesser wing of sphenoid above and medial to the superior rectus and above the medial rectus, and the inferior oblique takes origin from the orbital surface of the maxilla. Now, if you see the insertion, the 4 recti are inserted into the sclera between the equator and the corneoscleral junction. And the insertion is such a way that the medial rectus is 5 mm behind the corneoscleral junction, the inferior rectus is 6 mm behind the corneoscleral junction, the lateral rectus is 7 mm behind the corneoscleral junction, and superior rectus is 8 mm behind the corneoscleral junction. And if you observe, the superior oblique gets inserted to the posterior-superior lateral quadrant of the eyeball, and the inferior oblique also gets inserted to the posterior-superior lateral quadrant of the eyeball, exactly opposite the superior oblique. And if you see the nerve supply, all the voluntary extraocular muscles are supplied by the oculomotor nerve except superior oblique, which is supplied by the trochlear nerve, and lateral rectus, which is supplied by the abducens nerve. So SO4 and LR6. Remaining all voluntary muscles are supplied by the oculomotor nerve. And there are 3 involuntary muscles, namely the orbitalis, which will be bridging across the inferior orbital fissure, and there will be superior tarsus and inferior tarsal muscle. I'll show you here. You can see here. So this is the intermediate slip of the levator palpebrae superioris, which is forming the superior tarsal muscle, and here you can see the inferior tarsal muscle, which is derived from the connective tissue of the inferior rectus and inferior oblique. So these two are involuntary muscles, and along with that orbitalis. So all these 3 will be supplied by the sympathetic nerves. All these 3 will be supplied by the sympathetic nerves. So now we know the origin, insertion, nerve supply, and let us see the actions. Before seeing the actions, we should understand. You can see here, this is the antero-posterior axis of the eyeball, otherwise called the visual axis, and here you can see this is the orbital axis. So both are not in the same line. So there is an angle of 20 to 25 degrees between the orbital axis and the visual axis of the eyeball. And now let us see here. The axis of the superior rectus and the inferior rectus is forming 25 degrees angle with the visual axis of the eyeball, and when the eye is abducted, then the visual axis of the eyeball will come to line with the axis of the recti, superior rectus and inferior rectus. And here you can see the axis of the superior oblique is making an angle of 51 degrees with the visual axis. So when the eyeball is adducted, so then the visual axis comes in line with the axis of the superior oblique. You can see here the superior rectus is elevating, the medial rectus is adducting, and the lateral rectus is abducting, and you can see the inferior rectus is depressing. So you can see the superior oblique doing the intorsion. See, the superior oblique takes origin from the undersurface of the lesser wing of sphenoid, and it moves forward along the roof and medial wall, and anteriorly at the trochlea it changes the direction and gets attached to the posterior superior quadrant of the eyeball. So it is this directional change which is allowing the superior oblique to make intorsion of the eyeball. And you can see this is the inferior oblique taking origin from the orbital surface of the maxilla and getting inserted to the posterior superior quadrant, and here this direction of the muscle, when it contracts, it makes the extorsion. So you can see the superior rectus doing elevation and inferior rectus doing depression. Second, you can see the superior oblique performing the intorsion and inferior oblique performing the extorsion. So here you can see The superior rectus, along with the elevation, it is also forming the it is supporting the adduction as well as intorsion. The inferior rectus, it is also supporting the adduction, but it also supplying the extorsion. It also supporting the extorsion. So the recti are adductors. The recti are adductors, and the superior rectus is also helping in intorsion, whereas inferior rectus is helping in extorsion. So both I and I, inferior oblique and inferior rectus helps in extorsion, whereas superior rectus and superior oblique will help in intorsion. So now you can see this is the superior oblique performing intorsion, and this is the inferior oblique performing the extorsion. So what is this intorsion and extorsion? See, this is the 12 o'clock position of the cornea. So if the 12 o'clock position of the cornea rotates medially, then we call it as intorsion, and the same 12 o'clock position of the cornea, if it rotates outside or laterally, we call it as extorsion. So I will not go with I. That means inferior oblique and inferior rectus will not perform the intorsion. Inferior oblique and inferior rectus always performs the extorsion. The superior oblique and superior rectus performs the intorsion. So now let us see the actions of extraocular muscles. Medial rectus does adduction only, lateral rectus does abduction only, because both lie in the transverse plane. And here if you see the superior rectus in primary position, it will perform elevation, adduction and intorsion. And in adducted eye, it performs intorsion only, and in abducted eye, it performs elevation only. So inferior rectus mainly it performs depression. In addition, it assists in adduction and extortion. So in adducted eye, it performs extortion only. In abducted eye, it performs depression only. Superior oblique mainly it depresses the eyeball. In addition, it also abducts and also performs intorsion. So in adducted eye, it performs depression only. In abducted eye, it performs intorsion only. Inferior oblique mainly elevates the eyeball and assists in abduction and extorsion. So in the adducted eye, it elevates the eyeball, whereas in abducted eye, it performs extorsion. So if you see adduction, the main muscle for adduction is medial rectus. It is assisted by the both rectus, superior rectus and inferior rectus. Abduction is mainly by lateral rectus, assisted by superior and inferior oblique muscles. So obliques are abductors, recti are adductors. So elevation, superior rectus and inferior oblique in primary position, superior rectus only in abducted eye, inferior oblique only in adducted eye. So depression, inferior rectus and superior oblique in primary position, inferior rectus only in abducted eye and superior oblique only in adducted eye. So intorsion is by superior rectus and superior oblique, and here extorsion is inferior rectus and inferior oblique. So inferior rectus and inferior oblique will not go with the intorsion. So inferior rectus, inferior oblique always performs extorsion. So superior rectus and superior oblique performs the intorsion. So the same thing explained. Here you can see in the primary position, elevation is mainly by superior rectus and inferior oblique. So depression is mainly by the inferior rectus and superior oblique. So in the adducted eye, elevation is by the inferior oblique, and here you can see the adduction by medial rectus. So in the adducted eye, depression is by the superior oblique. So in the abducted eye, you can see the elevation is by superior rectus. You can see in the abducted eye, depression is by the inferior rectus, and here you can see abduction mainly performed by the lateral rectus. So here you can see the extorsion and intorsion movements. So extorsion is mainly by the inferior rectus and inferior oblique. Intorsion is mainly by the superior rectus and superior oblique. So you can see strabismus or squint. It is a unilateral paralysis of an individual muscle due to involvement of the nerves. So the actual problem is the real image falls on the macula of the unaffected eye. So in an unaffected eye, so the real image falls on the macula, whereas false image falls on the peripheral part of the retina on the paralyzed eye. So this is resulting in double vision or diplopia. So if you see the muscle paralyzed, if it is the lateral rectus muscle which is paralyzed, the involved nerve is abducent nerve, and it causes ipsilateral medial squint or internal squint. So if medial rectus is paralyzed, the nerve involved is oculomotor nerve. It causes ipsilateral lateral squint. With the superior oblique, so there is involvement of trochlear nerve, and there will be vertical squint. So I'll explain it again. Unilateral paralysis of individual muscle is due to involvement of the nerves, produces strabismus or squint, and may result in diplopia or double vision. So because light from an object will not be focused on the identical areas of both retinae. So in order to see an image properly, the image should be focused on the identical areas of both retina. The real image falls on the macula of the unaffected eye, and the false image is mediated from peripheral part of the retina of the paralyzed eye. Now let us see different scenarios like paralysis of lateral rectus produces internal strabismus. So diplopia appears on looking to the paralyzed side, and the false image lies lateral and parallel to the true image. So lateral rectus paralysis, false image lies lateral and parallel to true image. Same way medial rectus paralysis, the false image lies on medial and parallel to the true image. So in lateral rectus, diplopia appears on looking to the paralyzed side, whereas in medial rectus damage, the diplopia appears on looking to the sound side or the normal side. So you can see here, this is the right lateral rectus paralysis. You can see the false image is lateral to the true image. So, and here you can see this is the medial rectus paralysis. So you can see the false image lying medial to the true image. So involvement of superior rectus produces diplopia on looking up, and that of the inferior rectus on looking down. The false image is obliquely disposed and lies internal to the true image. When superior oblique is affected, diplopia occurs on looking down and the false image lies outside the true image and is obliquely disposed. In involvement of inferior oblique, diplopia occurs on looking up and the obliquely placed false image lies outside the true image. So now there are certain additional actions like conjugate movements and disjugate movements. So if you see the conjugate movements, both eyes moves in same direction and the axis will be parallel. Like if both eyes are turning towards right side, we call it as dextroduction. If both eyes turning to the left side, we call it as levoduction. And if both eyes going looking upwards, we call it as superduction. If both eyes looking downwards, we call it as subduction. So these are all conjugate movements, and there are disjugate movements like if both eyes are converging towards the nose, we call it as convergence. If both eyes are diverging looking laterally away, so we call it as divergence. Convergence and divergence are disjugation movements because eyeballs are moving in opposite direction. Same way, if one eye is looking up and the other eye is looking down, so we call it as circumvergence. We call it as circumvergence. These are the disjugate movements. Now coming to the levator palpebra superioris, as you can see here, it takes origin from the under surface of the lesser wing of sphenoid and moves forward. As it moves forward, it becomes fleshy. The lateral border will be concave, separating the orbital part and lacrimal part of the lacrimal gland, orbital and palpebral part of the lacrimal gland, and the medial margin will be straight, and anteriorly it divides into three slips, like you can see the upper slip, intermediate slip, and lower slip. The upper slip passes through the orbital septum, through the orbicular circuli, and gains attachment to the skin of the upper eyelid and also to the anterior surface of the superior tarsal plate, whereas the intermediate slip will form the superior tarsal muscle, which is one of the involuntary muscle. And here you can see the connective tissue from the levator palpebra superioris and the superior rectus both joining to form the final slip, which is inserted to the superior conjunctival fornix. And here you can see the inferior tarsal muscle, which is derived from the connective tissue of the inferior rectus and inferior oblique, so gaining attachment to the inferior border of the inferior tarsal plate. So paralysis of the levator palpebra superioris due to involvement of oculomotor nerve leads to complete ptosis, dropping of the upper eyelid, whereas the lesion of cervical sympathetic chain, as in Horner syndrome, leads to partial ptosis, partial drooping of the upper eyelid, as it affects only the smooth muscle part of the levator palpebra superioris. So now you can see here, so this is the lateral rectus muscle. See the connective tissue condensation, the check ligament of the lateral rectus, which is attached to the Wittnall's tubercle. Here you can see the check ligament of medial rectus, which is attached to the posterior lacrimal crest. And here you can see the suspensory ligament of eyeball, otherwise called as Lockwood's ligament, so which is holding the inferior oblique and inferior rectus. Whenever there is damage to the maxilla, so there will be no herniation of the eyeball below, because if this ligament is intact, it will support the eyeball. That's why it's called a suspensory ligament of the eyeball. So if suspensory ligament of the eye remains intact, when the floor of the orbit is fractured or the maxilla is removed surgically, the eyeball does not sag. So during enucleation of the eye, if Tenon's fascia is not damaged and artificial eye is planted subsequently within the socket of the Tenon's capsule, it is able to move. Thank you.